Hello and welcome to the Primary Care MSK podcast. This episode is on all things spinal management, so think those difficult spinal patients and how to manage them. So let's dive in.
And I'm here today with Thomas Dekkers. So Thomas, I'll let you introduce yourself. Tell us a bit about you and about your practice and everything like that.
Oh yeah, thanks Andy, pleasure to be here. So look, I've had an interest in back pain since I was actually quite young, probably from hanging around my father's GP clinic here in Ireland. I was always fascinated by back pain. So when I finished school, I didn't know which clinical route I was going to go in. I knew I wanted to work with patients with back pain, but I didn't know which area. So I did a degree in physiology first here at University College Cork, and then after that I decided to go into physio. Studied physiotherapy at the University of East Anglia in Norwich. And then following that, I spent a bit of time working in the NHS up to senior physio level in central London before moving into full-time private practice on Harley Street in central London. And so I spent about the bones of 10 years there, bar a 1-year journey to Australia to study my master's in University of Queensland. Came back to London for another spell and did some work with the English Institute of Sport with Team GB athletes. So started to develop more of an interest in athletes with back pain. And then after a number of years of that, I returned to Ireland to set up a private practice with my now wife, who I actually met on the course in University of Queensland. And so we worked together for a number of years. And then more recently, I've taken on an advanced practice role in the neurosurgery service at Cork University Hospital, as I wanted to specialise more in spines. And so my current work setup is that I work in the neurosurgical triage service. So I work alongside the neurosurgeons a number of days per week in their clinics. And I also hold a rehabilitation or physio caseload in Cork University Hospital, and that's mainly for maybe the complex post-surgical patients or those patients who've attended the neurosurgery clinic but who aren't appropriate for surgery, but who maybe have tried a few other treatments and are willing to maybe try a different route. And then I continue to work privately. That's where I am this evening after clinic. And there I see again predominantly a spinal caseload. I probably see a few more patients on the athletic spectrum, so I do still like to see a lot of athletes. And I'm also doing a PhD, so I'm about a year out from finishing that, hopefully. And then I also love to teach, so I teach around the application of exercise medicine for back pain. That's really my special interest. All right, so I suppose I work I am predominantly a clinician. I see patients with back pain and spinal pain every day. I see patients from many different demographics, many different socioeconomic backgrounds, different athletic status, and different ages. And so that's what I really like to see, that variety of people. But it is within the region of the spine is probably where I see the predominant amount of my patients from.
No, absolutely. I mean, that obviously sounds really interesting. You've got a few plates spinning there of various things. So tell us probably a little bit more about those patients that come to see you that aren't appropriate for surgery, and like you said, have tried a lot of things, because obviously in sort of first contact physio, first contact practitioners, we see a lot of those patients that are coming back because they've tried physio, it's failed, for want of a better term, is what they usually say, and but they aren't suitable for surgery. So how do you sort of break down those sort of barriers and things?
Sure. I suppose so, because I work in a neurosurgical service, so those patients are traditionally sent to us predominantly by GPs, and they normally have tried a number of different modalities, or the GP has felt that they need a neurosurgical opinion. And because of our weight, they've normally had a chance to bounce around a little bit. So when they come to see us, still, even from my triage clinics, only 10% need to go on to see the surgeon to discuss their surgical options. So you're talking about 90% of the patients I see don't need to see the surgeon, and they are referred to the neurosurgical service. So There's multiple reasons for that, but we'll have certain patients who are asymptomatic, all right, and they're very happy to be told that they don't need surgery. They probably put that together themselves. But there are certainly patients who have still persisting symptoms and they're not being offered surgery. And so I think the first way to manage that, Andy, is that we're supposed to explain why they're not being offered surgery, why there's no surgical target here. And for that, you need good anatomy and be able to interpret the MRI scans. And as I said, some people will be quite asymptomatic, so we'll leave them out. But those who still have pain, you might start seeing on the imaging, you'll have patients who still have persistent pain and who are quite disabled, who really don't have much going on their scan, right? So they've got lots of pain, lots of disability, but their scan maybe shows age-appropriate changes, but no signs of any significant pathology.
Yeah.
There'll be one group. And then you'll actually see people who have significant pathology. And I think we shouldn't forget that people with persistent pain may have significant pathology. That pathology may just not be amenable towards surgery. So you might see people who have multi-level degenerative changes, who maybe have multi-level things like canal stenosis, foraminal stenosis, multi-level disc bulges, which may all be nociceptive sources of someone's pain, but where the surgeon isn't willing to do surgery because they can't put their hand on heart and say that their pain is coming from one level, and therefore they don't know where to do the surgery. And other times we might see people with more unisegmental issues, such as a disc protrusion, which may be abutting a nerve, but it's maybe the disc isn't big enough, the prolapse isn't big enough for them to be considered for surgery. And so it's very important maybe to validate that person's pain and explain to them that why they're not getting surgery. And in all fairness, most patients are actually quite happy to not have surgery. I think spinal surgery has had a bit of a bad rep over the years. So most people are actually very happy to not be offered surgery. But then very quickly after that, the question comes, okay, well, what are we going to do? I've seen X amount of clinicians. I still have pain. Is this it for the rest of my life? And so that kind of probably leads me into the second part of the conversation. Which I'm probably having these conversations a number of times per week. So, but you do have to modify it for the patient. So once you've explained why there's no surgery being offered, I'd say what you believe is the causes of your pain, and maybe just get a bead on that. And normally they have a pathoanatomical view of their pain, either because that is quite natural, I think, actually. If you cut your finger and there's a cut, it hurts.
Yeah, because you think basically that there's got to be something
Absolutely
causing that pain, don't you? Realistically, there's an injury there or something like that you sort of that they're expecting.
Yeah, and I think that's very plausible. As I said, if you cut your finger and it hurts, and then when the cut heals up, the pain goes away. That's a very plausible reasonable thing to expect in your back. There must be an injury, and therefore, if we can just get it to heal, or to cut it out, or take it out, or restore it, your pain will go away. And you can explain that, and then, but very quickly with that, the conversation I moved towards the fact that pain is very multidimensional, right? And that yes, there may be pathoanatomical factors, but there's also factors related to how your body is processing pain. Things like neuropathic pain or nociplastic pain, where we're seeing a gross sensitivity of the pain system, if you like, and that you can get pain in the absence of any of significant pathoanatomical changes. And that can be a very new concept for many patients. So I'll pop that in, and I suppose a really good example for that with patients is that, look, you can say, look, I see people with disc bulges, disc prolapses all the time, who are asymptomatic, and when they hear that, they understand that that just because you have a disc bulge doesn't mean you have to have automatically got pain, right? Other things, psychosocial issues, of course, there's loads around that. We know that, but explaining this to a patient, that there might be other aspects to your pain, how you're thinking, how you're feeling about your pain, how you're behaving because of your pain. We know from Nadine Foster's work about 10 years ago that things like catastrophization, fear of movement, anxiety, and depression are all big predictors of long-term pain. There's been multiple studies done around that, and that we can kind of start to open the door a little bit to patients about that. And a lot of patients maybe really haven't thought about this. They might get the sensitivity aspect, but the psychosocial aspect is normally something that they.
Do you think in some ways that's worse with the back? Because I tend to find a lot of patients, you know, if it was in their leg, for example, or something, the knee or whatever, they wouldn't really think. They tend to catastrophize about the back. It seems to be like, you know, anything spinal has to be bad, sort of thing. Do you tend to find that?
Yeah, absolutely, absolutely, and it's very much a self-fulfilling prophecy, right? Because some people say 85%, some people 95%. I would say 99% of people on the planet, if they live long enough, will get some degree of back pain at some stage in their life, either significant or a few hours. But most people will get some degree of back pain, and how people maybe respond to having back pain versus foot pain is very different. And that's a societal thing, I think. You know, that backs are normally synonymous with high degrees of disability, and people normally hark to a family member or family friend who they know who was highly disabled because of their back, and you know that's in our psyche. But at the same time, and I've thought a bit about this. Why do people really catastrophize more about their back? But part of it is, well, you know, your lumbar spine, it's in the middle of your body. It's the epicenter physically in your body. So when you've got back pain, if ever you've had it, everything becomes a bit of a struggle. Walking, standing, lifting, bending, putting on your shoelaces. You know, if you have elbow pain, you can probably carry on with a good bit of your a good bit of your day without aggravating your elbow. But when you get back pain, it really infiltrates everything. So it adds to the problem, I think.
Yeah, no, absolutely. So how do you go about sort of helping those people, you know, that's, you know, like you said, explaining the pain and things like that to them? But how do we then sort of get those people from that sort of stage of, you know, being fairly dysfunctional when they obviously come to see you with those groups of people that have pain? How do you then get them into that sort of stage of, well, actually, we need to do something about this, and sort of what would you sort of suggest for those people?
Yeah, so you know, so once we've kind of spoken about the multidimensional nature of pain, that leads me into potentially ask them, so what has been, I said, so now that we know this about your pain, what kind of treatments have you had done before? And they'll say, oh, I had physio, and they did a bit of hands-on stuff, or they gave me some exercises and it was only a bit effective. I had a few injections, etc. And then I would say, okay, well, look, are you willing to try a slightly different approach where we really start to look at your pain, the things I've just spoken about? We start to look and treat you very holistically around the different factors that can be impacting your pain and disability. And at this stage, at least when they come to see me by this stage, because they've been waiting a while, they're normally very open to that. They're like, yeah, look, I've tried everything else. What is it?
Why not, sort of thing.
Absolutely. But the important thing is here is how to set them up for success when they come into these programs. And I have to be very cognizant of this, because these are the people in the neurosurgery service who I'm then referring to myself in the rehabilitation aspect. All right. So I'm setting myself up, and if people are referring into a pain service, it's about setting up the clinician in the pain service for a win, right?
Yeah.
And so I think very quickly with that, I say, okay, so there's rehabilitation processes that we can undergo that look at a very wide-ranging aspects of why you're getting pain, and what we can do is really start to work you towards improving your activity and improving your function. Yes, we want to reduce your pain, but ultimately what we're looking for is to start getting you back to doing the things you want to do, and for your pain not bothering you as much. And people say, oh yeah, that sounds great. I say, yeah, and then the reason I would start to say that is because so much of early musculoskeletal care is about pain reduction. You know, 99% of patients who come to see us, if you ask them what do they want, they normally say, I just want the pain to go, or I want the pain to go away. And I wish that was the case. I wish there was a technique or something that would abolish their pain and they can crack on with their life. But, you know, we know from, you know, even really good research like the Restore study last year with the CFT group, you know, big RCT, meticulously well done, showed to be effective over the long term. But what we're still seeing in a pain perspective, even with that approach, I think it was an average VAS score of 6 is what the patients came in on, and at the end of the program they had an average score of 4. So like you're talking about a 2-point difference on a VAS scale, which of course most patients would take 2-point difference, but it's not to say that those programs completely abolish pain, right?
No.
And so if we are setting people up to go into a program where they're expecting their pain to be abolished, that's setting up the person for a loss, really. So
Yeah.
it's about, yes, we'll see a reduction in your symptoms, but what we really want to do is really about enhancing activity. And so I will be asking you about how your symptoms are doing, but what I'm really more focused about is you getting back to doing the things you want to do, and you in being able to manage this yourself. And what we'll see over time is that your pain will come down, but it won't be the only thing that we look at. And that is so critical, because then by the time they come and see you, they know that we're going to take an active approach. I've told them that we're going to do that. I'm very exercise based, that you're going to get some exercises. We're going to talk about things. And by the time they come to see me, they've had time to stew on that and marinate it around it. And then they're ready to go, and they're ready to take a different approach. As opposed to me saying, I'm going to bring you into the department. We'll do some new techniques. We'll give you some different exercises, and you'll be blind. And you're really not going to get there with that approach.
No, exactly. And I think also I like that, setting them up for a win, basically, instead of sort of, and being around that. And I suppose that sort of leads on quite nicely to, obviously, we would refer into your type of service, really, in terms of neurosurgery and neurosurgery triage, especially. So what can we do sort of in primary care to get you that win, really, in terms of, set the patient up for, right, well, we are going to refer you, but we don't, especially those patients where we've done the MRI, for example, we can see that there's a disc bulge, they've got symptoms, so hence why we're referring on, because we haven't sort of got any improvement sort of in primary care. So we're referring on. Then, how do we sort of set that patient up for that expectation that almost that they're not going to get surgery, but we're referring to neurosurgery?
Yeah. So is this in the fact of a case who you want an opinion, but you don't think there's maybe a strong need for neurosurgery?
Yeah. So maybe just sort of seeing, we can see the disc bulge on the MRI. It's, it's compressing the nerve root or whatever, but it's single level. They've got some leg symptoms, that sort of thing, but no red flags, nothing that's going to really constitute a surgical response.
Sure.
So how do we set, but that patient saying, well, I've tried this, I've tried that. Is that something that you would say, well, yeah, we're going to refer into neurosurgery, or would that be something where you'd say, well, actually, we should be taking a different approach in primary care, for example?
Yeah, look, from those patients who come to see us in the neurosurgery department with that, maybe they've been referred with a degree of radicular pain. They've had a scan that doesn't look too bad. There's maybe a disc protrusion that's abutting the nerve, but maybe you feel like, look, this isn't something that the surgeons are going to do much about. There's an argument, I think, for both ways you can go. You can send them in with telling them, look, I don't think the neurosurgeon is going to do anything, but I'm going to give you the option, so that person feels like they've explored all their options. Okay, and now the neurosurgeon has said we're not going to do surgery. Now I can really bed in and crack on with the rehabilitation. I think setting themselves up for that is that they have other options in which to go down, and that unfortunately is what I see a lot of in our practice, is that people have been waiting to see a neurosurgeon for, in our case, years, because we've such a long waiting list. And in that time, they haven't been doing anything. They've been waiting because they've been holding out for this neurosurgical appointment. And it's very soul destroying for these people who've been waiting. They're off on disability. They're waiting for this appointment that's hopefully going to take away their pain, to be told, look, actually your symptoms aren't bad enough, or your pathology isn't bad enough to merit neurosurgery. And they're like, well, what do I do? What have I been doing for the last couple of years on the waiting list? So I think if you're going to send them and you feel like it's more for reassurance that they don't need surgery, they need to have another strategy running alongside that, where they're building resilience and they're working with it. You say, look, this is where I think you really need to focus on. By all means, let's get an opinion, but you need to be doing stuff in the meantime, because if you're just waiting for that opinion and you're going to get that in a few minutes of a consultation, we're going to have to do this stuff anyway. So you have to go back and do that deep rehabilitative work in the meantime.
No, exactly, and I think it's really important, like you said, to sort of set that expectation, isn't it? Because you don't want, I imagine there's must be thousands of people sat on waiting lists because they're going to see that person and they're going to do something. And realistically, we know that especially probably with neurosurgery, but also with other interventions, that they're not going to get that. And it's like you said, it's quite soul destroying for that person that's just sat there going, right, I've got that appointment now. They're gonna fix me.
Yeah, and look, in certain cases, I think it can be avoided. We get maybe a lot of referrals from GPs who've seen the scan, and maybe there has been some signs of pathology, maybe a moderate canal stenosis or something like that, but it doesn't match with that person's symptoms, all right? But they're priming that person to say, look, I think you need surgery, and then the person doesn't need surgery. So that can actually be quite problematic and damaging to the patient. It's of no fault or intentional fault of the clinician. No. But I'd say if people are referring into the service to see a surgeon, they have to have a pathoanatomical reason, preferably from an MRI scan, and then that matches up with their clinical presentation. And even if it's sub-surgical necessity, at least there's a reasoning process why they would have an opinion. Unfortunately, I see the odd few patients who really have no significant pathology on an MRI scan, yet they have persistent pain. And if there's a call then for the GP to refer in to see are they missing anything else. But for these people, maybe that could have been done in primary care, so they don't need to wait.
And really, like you said, really that then should go down sort of that pain management sort of more holistic route, rather than looking for something that, because then that's also quite damaging, isn't it? When the patient's expecting you, well, you're going to find the source of my pain, and realistically, like you said, there isn't always that source.
No, there's not, unfortunately.
Or pathological source, should we say, rather than there is a source of pain. But yeah.
I mean, our lead neurosurgeon, really, he a brilliant clinician. He just retired. He's been a neurosurgeon for 45 years, and having worked with him daily for a while, looking at scans, hundreds of scans in that time, I would ask him, where is the pain coming from, and seeing what his thoughts are as a clinician, because we know research-wise we can't be so certain. He says, I don't know. I see a disc bulge at that level, and I don't see any other pathology, so it's likely coming from that level, but I can't tell you if it's the bulge. I can't tell you if it's the facet joint. I can't tell you if it's the muscle. I can't tell you if it's the ligament. We can probably be segmentally specific, but not structurally specific. And I think that's well recognized within the clinical aspect. Telling that to patients, there's a subtle way to do it.
Yeah, and I think it's all about those sort of softer skills that maybe we don't sort of focus on as much as we should as clinicians quite often, in terms of communicating all these things that we know, and we can see in the literature and stuff like that, to a patient that's sat in front of you with pain.
Yeah, absolutely. It is a real skill. It's about how to give them the information and the knowledge that they really need. And we're always in a rush in neurosurgery clinics, so in the limited time that you have, but parcel it up in a way that person can understand. So depending on their health literacy status, depending on what they do for a living, I will have different analogies for a builder versus a mechanic versus a pharmacist, and I will modify my language accordingly, but all with the same message that I'm trying to convey. There's so much depth in it and nuance in it that it really is a case by case basis, and I suppose that's where we really need to go as MSK clinicians. We really need to do this patient centered mentality for all of us, really.
No, absolutely. And so we focused quite a lot there on sort of those patients that maybe shouldn't be referred in or should have other things done. What should be referred in? What do you see and you think, no, we can do something about this, and they are they're the people that we should be seeing?
Yeah, sure. So I should clarify, in the neurosurgery service, my job is predominantly in spinal, is only in spinal, should I say. I have seen a few people with brain tumors and things like that come in, and they need to be seen by a neurosurgeon straight away. But from a spinal perspective, okay, we've got our red flags, we've got our infections or malignancies. Our cauda equina obviously is an immediate emergency referral. We've got our rheumatological and neurological aspects that may be, when I say neurological, I mean neurological conditions, I saw a patient the other day who turned out to have motor neuron disease. So we need to be aware of those wider aspects that can give you peripheral symptoms, but maybe not from a spinal origin. So if we're all hopefully well versed on those things, when your alarm bells start ringing a little bit, and when you need to refer on, there's a grayer area just below that about an index of suspicion, but not severe enough that you actually think they should be sent directly to a neurosurgeon. So one of those, actually, I don't think that gets enough airtime, actually, is motor weakness, like I know that, okay, we're all drilled, hopefully, that if someone comes in with radicular symptoms, with a neurological deficit, that we need to be on guard. And the question is then, when does that person need to be referred? So I would say if you see a foot drop, right? If you have a foot drop, that's an emergency referral. In my book, that gets equal status to a cauda equina, and I don't think that's documented. At least I haven't read it, but certainly, if you're talking about a complete motor loss, and you're talking about maybe a large disc protrusion or extrusion that's compressing a nerve, if that nerve is not decompressed in a matter of hours, possibly days, you're talking about loss of motor function permanently. And I unfortunately have a number of patients on my clinical list who are in their 30s, who are wearing ankle foot orthosis for life. And I know bladder and bowel symptoms are obviously very debilitating, and I have those patients as well. But I don't think there's enough awareness brought to people with a foot drop or progressive muscle weakness. So certainly from the motor aspect, I would say anyone with less than a 4 out of 5, I would think in their initial consult needs to see a neurosurgeon or a spinal surgeon, and certainly anyone with less than a 2 or a 1 needs to go to the emergency if it's something that's acute. If it's something that's only happened in a number of weeks, I think they need to go. Sensory changes is slightly different. So sensory, I think our index of worry goes down a bit, a little bit of numbness or a little bit of funny sensations, a little bit of paresthesia with your radicular symptoms is something that I think we're more comfortable working with for a while in a conservative manner and a wait and see approach. If they really have a complete numbness, I would really be sending them on to see someone. And if there's anything along the lines of progressive neurology, I think that's a big one. If they're starting out maybe with pain that's then going into their leg, that then now they're getting tingling or numbness, or they're beginning to slap their foot a bit on the ground as they walk, that's indicative of a bit of dorsiflexor weakness, straight to the neurosurgeon. I wouldn't mess around with that stuff. And my index of worry, certainly around the motor aspects or progressive neurology, is quite high, because I see the cases who haven't been managed as well early doors, and the effects are catastrophic. They're lifelong,
Yeah, no, absolutely. And like you said, I don't think the motor aspect quite often is given as much airtime, like you said, as like cauda equina. We're all on it, as soon as you get those sort of symptoms, you're absolutely on it. So if we sort of take that patient that we sort of had before with sort of no red flags, persistent pain from a disc bulge, some neuro loss, say unilaterally, how long should a patient like that sort of try rehab for, do you think, before you're saying, well, actually this isn't getting any better? What do you sort of think in terms of time frame? I know it's difficult and it's patient specific.
Oh yeah, sure, of course. Yeah. What sort of neurological deficit?
So maybe sort of unilaterally, maybe sort of like you said, sort of maybe like sciatic symptoms, a little bit of intermittent numbness around the foot,
sure.
But no motor loss.
No motor loss. Okay, yes. For someone like that, I would probably say that I'd want to be giving them somewhere between 4 and 6 weeks. All right. So if you've got an acute, nasty radicular symptoms, pain-wise, radicular pain, it's really nasty, right? And if you can get over the first couple of weeks with medication from the GP, and you're not worried about any neurological deficit, there is a merit in maybe holding out a little bit, because a lot of symptoms in certain people do settle. But if they're really in quite a lot of pain after a month or 6 weeks, I'd be getting them to see the neurosurgeon. These are the patients not with like, I get a bit of pain in the evenings. These are the patients with really raging radicular pain. They're not sleeping at night. They're eating analgesia like Smarties, and it's not working. They need at the very least imaging, and then possibly if you can get into a neurosurgeon sooner than later, then just do that. I would say if they're improving, and this is the thing with these patients, thankfully for them, pain is normally the first thing to improve. So over time, their pain will improve, but they might still be left with some sensory disturbance. And if that's the case, that wouldn't worry me as much, as long as one aspect of their presentation is improving. Either their pain is improving in intensity, or it's radiating less distally. So it was in the foot, but now it's more in the thigh or the buttock. I'm a lot more happy that that's progress. They can also have a reduction in pain, and maybe that numbness or paresthesia is getting less. All those are nice signs of improvement. But really, if you're hitting the 4 to 6 week mark and they're not able to get anything more than temporary relief or no relief at all, I'd be sending them off.
Yeah. And would you sort of send those off for imaging, or would you send those off to neurosurgery for sort of triage and everything from there?
Yeah, so that would depend if they really have more on the motor deficit. I mean, at the end of this day, it actually depends how quickly we can see them. We can organize an MRI scan pretty quickly here. Someone at least privately will have an MRI scan within 24 to 48 hours. On the public system, it might take a little bit longer.
But
it's also a lot longer to see a neurosurgeon. So in a patient,
and we're in a similar boat, to be fair. So we can, we're probably talking, no more. We're probably talking sort of 4 to 8 weeks for an MRI, if sort of lucky, and then but neurosurgery, you're talking a long time.
Yeah, that's, at least we're not the only ones then. Yeah, so look, with them, imaging first, unless you're really worried about something that needs to be seen really soon. Someone with recalcitrant pain, with some mild neurological deficit, MRI first, see where we stand, and then decide whether they need to go on and see a surgeon. I think is the most prudent. Someone with really more progressive neurological symptoms, straight to see the neurosurgeon, and people with a foot drop or cauda equina straight to emergency.
Yeah, that's brilliant. Well, I think that's been a great insight. Thank you, Thomas, for your time. So, where can people find out more about you and more about what you're up to, especially sort of your teaching and that sort of thing?
Oh yeah. So yes. So I teach my weekend course around, I suppose, exercise prescription for back pain, and that's going to be I'm in London in October coming, and then I'm in the UK 2 or 3 times a year with that, a few times in Ireland and on the continent. So you can find that on Twitter is probably the easiest way. I'm active enough, depending on the month of the year. Instagram a little bit. I dip in and out of that, but I am around there with those. So anywhere on social media, people can find me. And if you're in the Cork region, or the Ireland region, I'm always willing to have people to come and spend time with me if that's what they also want to do. So there's no problem either way. I'm very open. If people want to send me a direct message, just even ask a clinical question, I'm always interested. I love this area, so I'm happy to help if I can.
No, absolutely, and obviously we'll have links to your social media down below as well, so that people can get in touch. But yes, thank you for your time.
Yeah, great, and I'm really impressed with what you guys are doing. I think it's on an ending note, it's a really important time for the physio profession, and the first contact roles are really important. They're really examples of how physios can step up and step into these roles, just as long as there's an adequate support, and that I'm sure the physios are going to prove themselves to be very very reliable in these roles. So keep doing what you guys are doing.
No, brilliant. No, thanks a lot for that. And we'll I'm sure we'll hopefully carry on and get some decent rehab and stuff like that in primary care.
Yeah, hopefully. Yeah.